There, my valued, highly treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time to share with you some precious tips which may prove useful in your line of duty. Welcome to part 57 of our pharmacotherapy MCQ series, which majors in pulmonology. The first question reads, Mr. J.P.O., a 20-year-old male patient, presents to your accident and emergency department complaining of a mild asthma exacerbation. He has a respiratory rate of 22, a pulse ox of 93 on room air. So my question to you is, which of the bronchodilatory therapies listed below would be the most appropriate for Mr. J.P.O.? Would it be Ibuprofen, continuous nebulization? Would it be an MDI form of salbutamol, or would it be salbutamol MDI with a holding chamber, or would you opt to continuously nebulize atropine? In this particular case, I'll give you 10 seconds to choose the correct answer. So C is the correct answer. I would opt for salbutamol with a holding chamber. Now, for acute asthma exacerbation, patients should receive short-acting beta agonists, what we abbreviate as SABA, SABA therapy, either as a high-dose nebulization or via a metered-dose inhaler, what we abbreviate as MDI, with a valved holding chamber. Now, salbutamol MDI without holding chamber requires patients to time the inhalation and actuation of the MDI device. Now, doing so poses a risk. It may risk suboptimal dosing in a severe acute scenario. A valved holding chamber doesn't rely on this timing and is preferred in acute cases of asthma exacerbation. There is no definite data that nebulized drug delivery is superior to an MDI with a valved holding chamber. Therefore, I would opt for alternative C because of those many words. I would just like to underscore the fact that atropine via continuous nebulization isn't ideal for acute asthma. You'd have many side effects. Now, while ibuprofen is an appropriate agent for severe acute asthma, it should be administered via intermittent nebulization rather than continuous nebulization. That makes alternative A wrong as well. Patients should be educated on appropriate techniques so that they may be able to manage the exacerbation at home before needing emergency care in an accident and emergency department. Now, while pulmonary function tests such as forced expiratory volume 1 can help guide asthma severity, They are rarely measured in the acute setting, e.g. in an accident and emergency department. And I would like to remind you that therapy is guided by physician assessment, oxygen saturation, and patient history. So those are key things when you're managing exacerbation of asthma. Let's move to the next question, please. The next question reads, PMG, a 16-year-old female asthma patient, has been well controlled for the past 6 months on her current regimen of mometasone 200 mics inhaler, and that is dosed at 1 inhalation once daily, alongside Salmeterol, which is dosed at 1 puff twice daily, together with a Prorenata Salbutamol inhaler, which she hasn't used over 6 months. My question to you is, which of the recommendations listed below would be the most appropriate for Ms. PMG? Would you opt to discontinue mometasone, to continue scheduled Salmeterol and Salbutamol PRN, or would you opt to discontinue Salbutamol as she isn't currently using it and continue with mometasone and Salmeterol, or would you discontinue Salmeterol and continue scheduled mometasone and Salbutamol PRN, or would you discontinue Salmeterol and mometasone and continue with Salbutamol Prorenata? I'll give you 10 seconds to choose the correct answer. I would opt to discontinue Salmeterol and to continue scheduled mometasone alongside Prorenata Salbutamol. Now, of the choices above, stopping Salmeterol, which is marketed as Cerevant, would be the most appropriate option, as this effectively steps Ms. PMG's therapy down from step 3 to step 2, which is appropriate to consider in patients with well-controlled asthma for greater than 3 months. Now, since the foundation of asthma therapy is an inhaled corticosteroid use, the ICS, discontinuing mometasone wouldn't be appropriate at all. Stopping both mometasone and Salmeterol would effectively step down this lady's therapy 2 steps, that is from step 3 to step 1, which is also not recommended. Now, short-acting beta-2 agonists, what we abbreviate as SABA, should always be available, Prorenata or PRN, as a quick relief medication in case of a sudden asthmatic attack. So all those many words clarify why C is the correct answer. Let's move to the next question, please. And it reads, Mrs. L.W.A, a 46-year-old female with a past medical history of chronic obstructive pulmonary disease, is admitted to your hospital for the treatment of COPD exacerbation. Now, during this admission, her FEV1 was measured and found to be 38% of her predicted value. So my question to you is, which of the vaccines listed below should be administered to Madam L.W.A now? Would it be a BCG vaccine, RZV vaccine, PPSV23 vaccine, or the PCV13 vaccine? I'll give you 10 seconds to choose the correct answer. I would opt to administer the PPSV23 vaccine. For patients below the age of 65 with COPD and whose FEV1 is less than 40% of the predicted value, the PPSV23 vaccine should be administered according to guidelines. Now, the GOLD guidelines also recommend the PPSV, what we call the 23-valent pneumococcal polysaccharide vaccine immunization for all patients above the age of 65 who have COPD. Now, alternative D, the PCV13 vaccine should be administered to patients with the COPD when they are 65 years, followed in 1 year's time by the PPSV23 vaccine, provided they haven't received the PPSV23 vaccine at any time in the previous 5 years. That's what the guidelines from CDC say. Now, the BCG vaccine, alternative A, is a vaccine primarily used against tuberculosis. It isn't the most appropriate vaccine for this patient at this time. Now, the RZV vaccine, which is an alternative B, is the perfect vaccine for shingles, according to the Advisory Committee on Immunization Practice, which is abbreviated as ACIP. That's a wing of CDC. And I would like to remind you that it isn't the most appropriate vaccine for this patient at this time. I would like to also remind you that influenza immunization is critical in patients with COPD since it can cause the risk of serious illness and even death to increase by 50%. Just as a by the way. Let's move to the next question, please. And it reads, Madam RMA, a female patient, presents to your pharmacy seeking to refill a prescription following her third asthma exacerbation in the past 1 month. My question to you is, which of the following would be the most appropriate method of assessing her inhaler technique? Would you choose to provide written instructions on inhaler technique, or would you opt to ask the patient to demonstrate the inhaler technique, or would you choose to demonstrate the appropriate technique and then ask the patient if it matches their technique, or would you simply switch the patient to a nebulizer? I'll give you 10 seconds to choose the correct answer. So I would opt to ask the patient to demonstrate their inhaler technique. Now, we know that incorrect technique occurs in up to 80% patients with asthma. The method to assess their current inhaler technique is to ask the patient to demonstrate their technique to you as a service provider. Now, after identifying issues, the pharmacist may choose to educate the patient on appropriate techniques using, for example, demonstrations, videos, and even checklists. Now, demonstrating inhaler technique to the patient and then asking if it matches their technique isn't appropriate. This may allow patients who feel embarrassed to agree with your demonstration when in reality they are using ineffective inhaler techniques. I would just like to emphasize that open-ended questions and demonstrations are the most effective. Now, only providing written instructions isn't appropriate for effective patient education, since patients may have difficulties reading, or they may also fail to fully understand the recommendations. Now, open-ended questions with demonstration of techniques when coaching on the correct technique is a preferred method. And I would also like to add that it isn't necessary to switch the patient's asthma regimen to a nebulizer. When assessing precipitating factors for uncontrolled asthma or frequent exacerbations, inhaler technique is usually often identified as the problem. Many treatments fail because of poor inhaler technique. Now, proper open-ended questions followed by demonstrations of the correct technique with addition of videos or checklists is the ideal according to many forms of literature available out there. Now, I would also like to add that patients with frequent exacerbations should also be assessed for excessive salbutamol use, since it's common knowledge that this may be associated with beta-2 receptor downregulation that may lead to bad outcomes or poorly controlled asthma. Let's move to the next question, please. And it reads, which of the statements listed below is or are true about the use of Roflumilast in the management of chronic obstructive pulmonary disease, abbreviated as COPD? Is it true that it is known to cause significant weight loss? Or is it true that it is administered orally as a tablet? Or is it true that it inhibits phosphodiesterase 3 enzyme? Or is it true that it is also recommended by the GINA guidelines as an alternative treatment for asthma? Or is it true that it increases cyclic AMP levels due to inhibition of phosphodiesterase 4? I'll give you 10 seconds to choose the correct answer. So answers A, B, and E are all correct. Now, Roflumilast, which is marketed as Daliresp, is a phosphodiesterase 4 inhibitor that comes as an oral tablet and is administered once daily for the chronic management of chronic obstructive pulmonary disease. Now, while some medications for the management of COPD come in capsule formulation that are usually placed in the devices for inhalation, Roflumilast is one of the few oral options used in the management of COPD. Now, a common side effect that warrants close monitoring is the weight loss associated with Roflumilast. Now, this Roflumilast shouldn't be used in the management of acute COPD exacerbation, since it is only approved by FDA for the chronic management of COPD. Now, all those explanations explain and justify why alternatives A, B, and E are the correct options in this particular question. Let's move to the next question, please. And it reads, which of the medications listed below with bronchodilatory effects used in the management of asthma and COPD are subjected to drug-drug interactions with inhibitors and inducers of CYP450-1A2 and CYP450-3A4 enzyme systems? Is it levoalbuterol, salbutamol, which is marketed as Zopenex? Or is it omalizumab, marketed as Xolair? Or is it Theophylline, marketed as Untitled? Or is it Montelukast, which is marketed as Singulair? I'll give you 10 seconds to choose the correct answer. Theophylline or Untitled it is. Now, the only medication listed above which is known to be a substrate of both CYP1A2 and CYP3A4 is theophylline, and it is known to result in many drug-drug interactions. Now, I'd just like to emphasize that strong inhibitors of CYP1A include amiodarone, ciprofloxacin, and fluvoxamine, while strong inhibitors of CYP3A4 include amiodarone, erythromycin, verapamil, and even the protease inhibitors used in the management of HIV. Now, inducers of these enzymes include phenytoin, for example, phenobarbital, carbamazepine, and even rifampicin, which is used in the management of TB, among other conditions. Now, I'd just like to emphasize that theophylline is a non-selective phosphodiesterase inhibitor, which is sometimes used in the management of asthma and COPD, but is unfortunately known to cause many drug-drug interactions, and it also requires serum or blood level monitoring. Now, I would like to remind you that the therapeutic serum concentrations of theophylline should fall in the range of 10 to 20 micrograms per ml. That's just for your information. Let's move to the next question, please. And it reads, your clinical team is reviewing clinical notes of a patient who has reported for a routine appointment, and one of the reports reads, and I quote, patient with pulmonary inflammation and airflow limitation noted by the presence of increased neutrophils and TNF-alpha and IL-8 mediators. End of quote. My question to you is, basing on this information, which of the diagnoses listed below is the most likely for this patient? Is it asthma, cystic fibrosis, COPD, or obstructive sleep apnea? I'll give you 10 seconds to choose the correct answer. So COPD it is. Features associated with inflammation in COPD include, for example, the presence of increased cells like the neutrophils, the macrophages, and mediators like the IL-8 and TNF-alpha. Now, this differs from asthma, where the primary cell increase and pathology is due to eosinophils and mediators such as IL-4 and IL-5. Now, these markers are less likely with cystic fibrosis and obstructive sleep apnea alone. So that makes C our correct answer in this particular question. Let's move to the next slide, please. And the next question reads, which of the following medications listed below doesn't increase the risk of asthma exacerbation? Is it Timolol ophthalmic solution, Ibuprofen suspension, Ondansetron, or is it aspirin tablets? I'll give you 10 seconds to choose the correct answer. So Ondansetron it is. Now, Ondansetron isn't associated with increased risks of asthma exacerbation. Patients with a previous history of hypersensitivity to this particular product may experience bronchospasms, but this would be related to anaphylaxis and not asthma. Now, Timolol, on the other hand, although used as an ophthalmic beta blocker, may still achieve measurable systemic concentrations. Its use in patients with a history of asthma is contraindicated according to the literature insert. Now, NSAIDs like ibuprofen and medications like aspirin are associated with acute asthma exacerbation with increasing prevalence with the increasing age of patients who have developed resistance to corticosteroids especially. Now, patients who have worsening asthma with NSAIDs or with aspirin, however, have compelling indications for these agents. And when this is so, leukotriene receptor antagonists may be useful. Now, I would like to add that vitamin D insufficiency has been identified as a risk factor for uncontrolled asthma, especially in the children. So you may want to consider supplementation of the same in the asthmatic population if the levels are low according to your lab tests. Let's move to the next question, please. And it reads, Mr. KTM, a male patient, presents to your clinic complaining of daily intermittent episodes of shortness of breath and whistling sounds when breathing, which is associated more with exercise, but not exclusively to exercise. Now, during these episodes, the patient says, this Mr. KTM says, he has to sit down and rest for the symptoms to subside. Now, when probed, Mr. KTM claims that he occasionally wakes up at night coughing for no apparent reason, in his own words. His nighttime coughing has occurred thrice in the last 30 days, in the last 1 month. Now, your chest physician at the clinic today diagnoses asthma. So my question to you is, how would this patient be classified? Would you classify his case as a mild persistent case, a mild intermittent case, a moderate persistent case, or a severe persistent case? I'll give you 10 seconds to choose the correct answer. This is a clear case of moderate persistent asthma. Now, based on the L.W.A guidelines, this patient falls in the category of moderate persistent. I would like to remind you that reviewing the classification schemes for a patient that is equal to or above the age of 12 and even the adult population, this patient is experiencing daily daytime symptoms. Remember, we are told about wheezing and shortness of breath, which falls into the moderate persistent category or classification. But notes only, if I remember well, 3 nighttime symptoms in the last 30 days. So that makes it mild persistent classification. So I would like to remind you that when there is conflicting data, then we are supposed to assign the severity of asthma based on the most severe classification. So in this case, some symptoms placed our patient in the moderate persistent, others placed the patient in the mild persistent. So we would eventually end up classifying his case as moderate persistent, which is the more severe of the two. Let's move to the next question, please. It reads, Mrs. A.J.O., a 26-year-old female with a known past medical history of asthma, which has required prior hospitalization and intubation with mechanical ventilation, with her last exacerbation, comes in by ambulance with shortness of breath, worsening over the past 24 hours. That isn't responding to her use of salbutamol nebulizer at home. AJO receives methylprednisolone at a dose of 40 milligrams IV stat, and she is now getting continuous salbutamol by nebulization on arrival after receiving an initial dose of ipratropium and salbutamol. Now, AJO is still able to communicate by shaking her head, by nodding yes or no? So my question to you is, what other intervention could be implemented in AJO's case now? Would you choose to administer azithromycin at a dose of 500 milligrams via IV infusion over an hour start? Or would you administer theophylline at a dose of 4.6 milligrams per kilo via IV infusion? Or would you administer magnesium sulfate 2 grams via IV infusion over a period of 20 minutes? Or would you choose to inject 10 milligrams of dexamethasone IV start? I'll give you 10 seconds to choose the correct answer. So I would opt to infuse 2 grams of magnesium sulfate over 20 minutes. Now, in an effort to prevent intubation in AJO's case, magnesium sulfate can be useful in helping patients like her who have already received proper bronchodilatory and steroid therapy. Now, we know that magnesium sulfate is thought to function as a calcium channel blocker, since magnesium itself is also a divalent cation, just like calcium is. Thereby, it can cause smooth muscle relaxation in the bronchioles, to be specific, and this would result in bronchodilation and ease the patient's difficulty of breathing. Now, antibiotics such as azithromycin in alternative A aren't useful in the acute setting where prevention of intubation is the greatest concern. AJO may very well need an antibiotic, but the next best answer isn't administration of azithromycin, as she urgently needs bronchodilation and not an antibiotic at this stage. Now, alternative B, theophylline, is generally by the guidelines used for acute asthma exacerbation. Now, administering another steroid like dexamethasone isn't likely going to offer any acute benefit, especially since there is a delay in the onset of steroid effect. So I would not opt for D. Now, I would like to remind you that magnesium sulfate is used in the management of acute asthma exacerbations that haven't adequately responded to steroids and nebulized bronchodilator therapy. I would just also like to mention, as a by the way, that racemic epinephrine is another treatment that could be tried in the above scenario, and you'd prepare the solution by diluting 0.5 ml of epinephrine 1 to 1000 in 2.5 ml of normal saline and nebulizing the resultant diluted solution. So, my highly esteemed viewers and listeners, that brings us to the end of this video. Now, if this video benefited you in any way, I would like to remind you to give it a thumbs up and to like it and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you that the best is yet to come. Thank you very much for viewing this video and for listening to me. I sincerely appreciate your partnership and your continued support and very kind collaboration. And I look forward to interacting with you in part 58 of our series. Thank you very much.